Oh, sorry.
Where is the screen? Oh, sorry.
Sir, we might have this disturbance for 2-3 minutes because the back office they are not able to mute. So just 2 minutes they are asking for.
Shall we
We'll
stop?
sort. Just 2 minutes, sir. Just 2 minutes.
Okay.
सर तू यूट्यूबर है अच्छा यूट्यूबर पण असतो हे घे ना त्यांचा लिंक घे ना
Shall we start? Sarang?
Yes, sir.
So I would like to thank the MCNS webinar committee, Chairman Dr. Atul Goyal sir, Co-Chairman Dr. Kishore Chaudhary, Dr. Dattatreya Mudumdar, and moderators Dr. Abhay Kumar, Dr. Pramod Giri, Dr. Ranjit Deshmukh, Dr. Chandan Mohanty, and convener Dr. Sarang Rote. This year was they have done a tremendous work to make this series successful. I'm sorry. So today is the last webinar of this year series, and for this series, for today's webinar, we have moderator Dr. Dattatreya Mudumdar and Dr. Chandan Mohanty. Both are from Mumbai, and we have eminent panelists Dr. Anil Karaputra sir, Dr. B.K. Mishra, and Dr. Botuk Deora from Mumbai only. And the speakers are Dr. Sudhir Ambekar. He will be talking on carotid endarterectomy. Followed by, if Dr. Rakeshin joins, then carotid stenting, and Dr. Shiv Shankar Marjakke will be talking on STA MCA bypass, and this will be followed by a discussion. So with this short and sweet introduction, I hand over to Dr. Chandan. Chandan, please take over.
So good evening, everybody. So we're excited for the last webinar of this month, and we hopefully all of us will meet in person in Kolhapur. So looking forward to that. So without wasting any time, so we will have basically three speakers. First will be Dr. Sudhir Ambekar, who will be talking about how I do it, carotid endarterectomy. We will probably have questions and comments from the panelists after all the talks, and then if there are any questions in the chat box, we will answer them individually. So over to you, Dr. Sudhir.
Yeah. Thank you, everyone. Okay, are my slides visible?
Yes.
Okay, all right. So I'll just go through the steps of carotid endarterectomy. Okay, so this is a 65-year-old gentleman with multiple episodes of transient ischemic attacks involving right arm and leg in the past 3 months. He was investigated at a local hospital, was diagnosed with left internal carotid, cervical internal carotid artery stenosis, and was started on medical management. However, there was no improvement. There was episodes persisted, and that is when he was further referred to us for treatment. Initial imaging MRI of the brain did not show any infarct or any acute infarct or gliosis. MR angio initially had shown non-visualization of the left internal carotid artery. It was a time of flight angiography. But then later on, the neurologist did the CT angiography, which showed severe internal carotid artery stenosis. This is the CT angiography showing severe internal carotid artery stenosis, and this is the angiogram showing critical occlusion of the cervical internal carotid artery. Of note, the distal internal carotid artery is of good caliber, and he was initially the treating interventionist had tried to do okay. Yeah, yeah. For some reason, they were not able to pass the wire distal to the area of stenosis, and that is when he was referred for carotid endarterectomy. Regarding preoperative considerations, am I audible?
Yes, yes.
Yeah. Okay.
You're audible.
Regarding preoperative considerations, whenever the patient is on dual antiplatelets, I always stop clopidogrel at least 3 to 4 days prior to the day of endarterectomy. I continue aspirin 150 milligrams. Sometimes, if the patient is very high risk, then we continue both the antiplatelets, but we would want to stop clopidogrel and continue aspirin. When it comes to planning of surgery, we always look at the level of bifurcation of the common carotid artery. This is important because we always need to, when we expose, we need to get distal to the level of stenosis. So if the level of bifurcation is very high, that is above C2 or C1 level, then it becomes difficult to expose the internal carotid artery. In that case, we may need to go more cranially and under the mandible. Sometimes we may need to expose the parotid gland or the submandibular gland, and sometimes we may have to do a mandibular split. Although I have never done a mandibular split also. So level of bifurcation is extremely important while planning endarterectomy. What is the length of stenosis? If it is a short segment stenosis, long segment stenosis, if the stenosis is involving the common carotid artery, the bifurcation, or it's only the internal carotid artery, all this needs to be understood, studied carefully in the preoperative angiography or a CT angiography. Also, as I said earlier, we need to know what is the intracranial internal carotid artery patency, if the intracranial ICA is patent or if there is associated atherosclerosis and stenosis in the intracranial ICA. We also need to look at the cross circulation across anterior communicating artery and the posterior communicating artery, because we are going to essentially stop the circulation or stop the flow through the internal carotid artery for some period of time. So we need to understand what is the cross circulation, if that is okay, if it is okay to stop or not. We look at the opposite internal carotid artery patency. I personally do not do endarterectomy if there is bilateral critical stenosis. I always try to do stenting. But if the opposite ICA patency is important, because we are going to occlude the flow for a short period of time. So we need to know what is the cross circulation, whether the opposite IC is able to compensate for the blood flow for that the occlusion time or not. And lastly, the tortuosity of the internal carotid artery. Also, we need to understand what is the, if the internal carotid artery is too tortuous, if it's forming a loop. All this needs to be studied in the preoperative angiogram or a CT angiogram before we go ahead with the surgery. Coming to the surgery, this is the position we always lay the patient supine on the head ring with a slight extension and turning to the opposite side so that the sternocleidomastoid is prominent. The incision is made along the medial border of the sternocleidomastoid.
Your slides are not moving.
Okay. Sir, it is a video.
Video is your first slide is only there.
Oh, okay. Let me just check, sir.
We are at the preoperative consideration.
Yes, sir.
Yeah.
Yes, sir. Now is the video seen, sir?
No.
Okay. Is the video seen now? No.
No.
Okay.
Screen is frozen. So
Okay.
moving.
I'll just stop sharing and then start sharing.
Yeah.
Is it seen, sir?
Yeah, yeah.
Yes.
Okay. So this is we just lay the patient supine on the with the head position on the head ring, and then okay, let me see. Yeah, for some reason I'm not able to play the video here. Okay, now is the video seen, sir?
No, it is at frozen. The video is frozen.
Okay. I think it is.
Yeah, yeah. Now it is moving. Yeah. Yeah.
Okay. So after preoperative preparation, we give a oblique incision along the medial border of the sternocleidomastoid, and we go along the medial border of the sternocleidomastoid on the cervical fascia, and always palpate the common carotid. Just palpate the common carotid. Go along the medial border of sternocleidomastoid. Sometimes we may have to cut the omohyoid muscle, and this is the omohyoid muscle that is being cut. And then we develop a plane along the medial border of sternocleidomastoid to expose the internal jugular vein, the carotid sheath, common carotid artery. Once we open the carotid sheath, we see the vagus nerve that lies between the common carotid artery, and this is the facial vein that is being clamped and suture ligated. We can either put a clip, but it is always, even if we put a clip, it is better to ligate it using a suture so that later on there is no bleeding from the common facial vein. Yeah. So after this, we go medial to the internal jugular vein. We identify the common carotid artery. Yeah, this is the vagus nerve that is seen between the common carotid artery and the internal jugular vein. At this point of time, once the vessels are exposed, this is the common carotid artery, the external carotid artery, internal carotid artery. This is the superior thyroid artery. It is important to identify the superior thyroid artery and take a loop around it, because very often when we occlude the external carotid artery, there is still bleeding from the superior thyroid artery because it just originates just at the bifurcation. Once we take a loop, we use a Doppler to see how the flow is. It's just for academic purpose. We do not have flowmetry as yet in our hospital, but we always use a Doppler to see how the flow is in the common carotid artery, internal and external carotid artery. And then we start clamping the internal carotid artery first, common external carotid, and then common carotid artery. And then we give a linear incision starting from the common carotid artery across the bifurcation into the internal carotid artery. We extend the incision, and then using a micro dissector, we dissect the plaque all along. It is important here to understand that we do not dissect the wall of the artery, because dissecting the wall can create flaps and later on can cause thromboembolism. So it is very important to create a plane between the plaque and the wall, and dissect the plaque from the wall of the artery. Again, it is here at some points, if we feel that the plaque is too adherent, we can just amputate the plaque cut the plaque at that end. And if there are any tags of the plaque present, then we take a 6O or a 7O proline, and then we just stabilize those plaques to the wall of the artery so that they are not free floating flaps, and they again do not lead to dissection. Here, the plaque is being removed from the external carotid artery and amputated. This is, this is the plaque being removed from the external carotid artery. The plaque is amputated, and throughout the endarterectomy process, opening of the artery and removal of the plaque, we irrigate with heparinized saline. We also give 5,000 unit, 50 to 70 units per kilograms of loading heparin just prior to clamping. This is a polytetrafluoroethylene graft that is being used, a patch that is being used to close the arteriotomy. We can either close primarily or use a graft. I usually tend to use patch whenever possible, although the patch is slightly expensive, but whenever possible, I tend to use a patch. First, we sew the patch to both the ends using 6-O-proline, and then we take running sutures all along the sides, making sure that the sutures are well placed, close by, tight, and there is no overlap of the sutures. And during this time, we always irrigate, make sure that there are no plaques there. And just before taking the final stage, we always back bleed. We always release the internal carotid artery to some extent, make sure that there is back bleeding, release the external carotid artery, and finally the common carotid artery to make sure that there is no air or any other debris that is there in the arteries. And then take the final stitch. At this point of time, once we have achieved this closure of the arteriotomy, then we release the clamps first in the external carotid artery, then common carotid artery, and then finally in the internal carotid artery. And then before closing, we reverse the anticoagulation with protamine. If needed, we can apply some Surgicel over the closure of the arteriotomy to achieve hemostasis. This is the ansi cervicalis that has come close to the this is the ansi cervicalis that has come close to the external carotid artery. And the hypoglossal nerve. One needs to be careful about it while dissection, because we should not cause any hypoglossal nerve injury. Once the hemostasis is achieved, we start closure. We can close the carotid sheath, and then we can close the cervical fascia. We can put a JP drain, a small drain for a day, just to make sure, because sometimes hemostasis is again important here because the patient is on anticoagulation. Antiplatelet agents. So one has to be very careful and make sure that the hemostasis is achieved before closure. And after the JP drain and subcuticular sutures, I think procedure is done. One other thing that is important to understand here is other thing that is important here to understand is that we always use cerebral oximetry. That is, we measure the cerebral blood flow in both hemispheres of the brain to make sure that the blood flow is maintained. There is no hypoperfusion of one side of the brain. We increase the blood pressure while the clamps are being placed. There is one more. So another few things that need to be considered during endarterectomy are use of heparin. One has to always anticoagulate before clamping. After giving a bolus IV dose, wait for 5 to 8 minutes before clamping. Always while clamping, clamp the internal carotid artery, then external carotid artery and common carotid artery. And while releasing before releasing the clamps, make sure that the back bleeding is present so that all the debris and the air is removed from the arteriotomy site. When we are releasing, always release the external carotid artery first, then the common carotid artery, and then the internal carotid artery in the end. I have rarely had to use a shunt. Most often we do not use a shunt. Again, because probably of my choice of cases where I don't usually do bilateral internal carotid artery stenosis. Use of a shunt when can be done. It's not very difficult, but then sometimes it may be a little bit cumbersome in the beginning. Use of a patch, we can use either PTFE patch or a bovine pericardium. Bovine pericardium tends to calcify over a long period of time. So PTFE patch is the patch of choice for us. Sometimes if the artery is big enough, then we can do direct closure. And during dissection, one needs to make sure that one avoids excessive manipulation of the artery to cause any thromboembolism during dissection. So these are some of the points we should keep in mind during carotid endarterectomy. I think that's it.
Thank you, Dr. Sudhir, for that excellent presentation. I would, I think, since Dr. Rakesh Singh is not available today, I'll request Harapurkar sir to begin his presentation on carotid stenting.
Sir, can I just ask like a couple of questions to sir about endarterectomy concept, if at all we can now?
So we will be taking the questions
Okay.
in the end. Yeah.
Okay, okay.
Thanks.
Thank you, Sudhir. Your presentation was very clear. And maybe mine will be a little more detailed about the indication and all that. So I'm substituting for Dr. Rakesh, who's busy doing a stroke, M1 stroke. So we'll talk about angioplasty stenting of the carotid artery. And what are the indications? Patients which are symptomatic and asymptomatic. Very rarely do we do, only if it is more than 90%. Post-radiation stenosis, I think you cannot opt, is one of the contraindications of surgery. Post-carotid endarterectomy stenosis or a carotid blowout, aneurysms of the cervical carotid. And sometimes we have had fistulae of the arteriovenous fistula in the neck between the carotid and the jugular. Symptomatic, of course, transient ischemic attacks we should do as soon as possible. Minor stroke, major stroke with recovery, and major stroke without recovery but with TIA. If the patient has had a major stroke and has not recovered, we don't do anything, we leave them alone. Asymptomatic, only if it is bilateral. Unilateral, if it is more than 90%, if there is a vulnerable plaque. So for which we do to diagnose a vulnerable plaque, we do a plaque morphology MRI. If there is a carotid web, of course, we should treat it because these patients come back again and again with TIA. Rarely we've done for a bypass, before a coronary artery bypass. And the youngest that we have done is a 34-year-old, and the oldest that we have done is a 99-year-old. So, just to show you, this is a web. So this web is a cause for stroke for TIAs. This web should be treated. I won't go into how you diagnose a vulnerable plaque. You can read up. What are the contraindications? Antiplatelet intolerance. If a patient needs major surgery, like prostate or knee hip replacement, we tell them to go ahead and do that first and then come for the stenting. Intraluminal thrombus is for me an absolute contraindication. Concentric calcification is again an absolute contraindication. Specific angiographic findings and contrast nephropathy if the patient cannot tolerate contrast, because we have to have contrast when we are doing any endovascular procedure. So if there's a large infarct like this one, we wait for 4 weeks and then we do the. So this is a very tortuous artery, and intraluminal thrombus is an absolute contraindication for me. Comorbidities are very common. Most of our patients have ischemic heart disease. Many have peripheral vascular disease. Some have renal artery disease, diabetes, hypertension, obesity, and hypercholesterol. Homocystinemia are very common in most of our patients. Patients over 75 have special problems. The arteries are very tortuous, irregular. Sometimes the opposite artery may be occluded. There are multiple comorbidities. There is a poor cardiac reserve. and there's a poor cerebrovascular reserve. So these patients, even with a minor change in the hemodynamics, don't take it too well. We always do a pre-stenting evaluation with a 2D precordial 2D echo, if required a transesophageal echo. A Doppler is usually done by the neurologists, but we prefer an MR angio. CT angio I don't like so much because if there is calcification, it obscures what we want to see. Rarely we have done SPECT with IV acetazolamide challenge. But the standard, of course, is the gold standard is, of course, the DSA. So this is a Doppler, this is a non-contrast scan, this is a NMRI showing a wet stupid infarct, and this is a severe stenosis. And this is, one should always look at the intracranial circulation also, not only look at the neck. I have seen many cardiologists and peripheral guys doing carotid stenting. They don't look at the head at all. They don't look at the collateral circulation. So one can miss tandem lesions if you don't look at the head. There may be a stenosis upstairs which is missed. So standard treatment, medical aspirin, clopidogrel, antistatins, despite which there can be a 13 to 16% risk of stroke. And arterectomy, the risk of stroke is much less. Endovascular, I've said here it should be 1 to 3, but often it is more than that because some small particles may still go across the filter that we use. So I told you earlier that this is for me an absolute contraindication. And this patient had an arterectomy done. Incidentally, he had a restenosis 10 years later, and he needed to have an angioplasty stenting done. When do we do the stenting? I think after a major stroke, like I said earlier, we wait for 4 weeks for the blood-brain barrier to heal. Otherwise, there is a very high risk of a pale infarct becoming a red infarct. But recently, only over the last 30 years that we have been doing this, there will probably have been 2 or 3 patients where we have done the stenting urgently, despite a large infarct, because of recurrent TIAs or recurrent stroke, despite anticoagulation, despite the full double antiplatelet and low molecular weight happen. But that is very rare. After major stroke, contralateral side may be treated immediately to improve collateral circulation. After a TIA, we should do it as soon as possible before the guy gets a stroke. Sometimes there may be just watershed areas. You see a string of pearls between the AC and MCA territory. These should be treated early. Emergency stenting for flurry of TIAs or minor stroke, we usually use a double layered stent. I'll show you the example. Usually when we are doing a stenting today, we use some form of protection. This was the first protection that was used. This was a balloon which was placed in the internal carotid beyond the stenting. And then the angioplasty stenting was done on the same wire. Now what we use commonly is a filter which is placed distally. So this filter, we cross the stenosis with a delicate wire, and either the filter is on the same wire or we exchange the wire for another filter. So the most common one, favorite one of ours, is either the spider or the EPI filter. These are the ones which have the lowest profile. So even with a very tight stenosis, these go across. Embo shield and angioguard have bigger nose cone, so it is difficult to take them across very tight stenosis. The endovascular clamping, which is done with this balloon, double balloon catheter. This technique is called either the MoMA or the Parodi. And here the one balloon is placed in the common carotid, one balloon is placed in the external carotid, and then the angioplasty stenting is done. So people where there is a intraluminal thrombus, do it with a MAMO or a MoMA or a Parodi, but I prefer to wait in such patients, either do an arterectomy or give low molecular weight heparin, let the thrombus disappear, and then do it after 6 weeks, do the angioplasty stenting after 6 weeks. So I've already said that we do a complete evaluation. And if the patient gets a new stroke or a new TIA, even on the morning, we do a fresh imaging to make sure whether there is any new infarct or not. If there is none, then we can continue. Or even if it is very tiny, we continue. Aspirin, clopidogrel, and high dose antistatin are of course given. And when we do emergency stenting, either we give ticagrelor, we use aspirin and clopidogrel, but in emergency stenting, we use ticagrelor, Brilinta, which is a more effective and very quick half-life. So these are just, one should always look at the plaque in at least two planes. So this is an ulcer which projects into the wall. A plaque projects into the lumen. So this is a plaque and this is an ulcer. So often these are ulcerated plaques. So this again, a very tortuous artery, a bovine arch is for me a contraindication. Sharp angulations like these are not a contraindication. One should always look at the disease in at least two planes, not only in one plane. Always lateral and AP or RAO or whatever, but one should always look at it in two planes. As far as possible, we do it under local anesthesia or monitored anesthetic care. Rarely have we done this angioplasty stenting under GA. Most often it is if the patient has a language problem or if the patient is aphasic. We prefer the femoral artery access. We use the short sheet. So let me show you the stents. I won't go into these technical details. So this is just a short video to show how it is done. So animation actually. So there is a plaque here. There is a severe stenosis. So this is crossed with a wire. The filter is on the wire. When we pull the sheet back, the filter gets deployed. We bring a balloon up, open it. The balloon is usually a 2.5 to 4 mm in diameter and 20 mm long. Any debris is caught there. This is a self-expanding stent. We prefer the wall stent as far as possible. It is a closed cell design stent. And once we have done, if required, if the stent does not fully open, then we use a second balloon to open it. Most of the debris which is released is during the stenting of the angioplasty of the stent. And then we retrieve the filter. So these are the steps. So we use an 8F sheath today. We use an 8F guide catheter or a 6F long sheath. I personally like the STR guide catheter. We cross the stenosis with a soft wire 014. We deploy the filter across beyond the stenosis. We always try to give 0.6 atropine to our patients. Sometimes we give glycopyrrolate. If the patient is above 80, we give half the dose. We give 0.3 milligrams. Angioplasty, if the stenosis is very severe, it usually is, but supposing it is for a plaque or for a vulnerable plaque or for a web, then we may not need to do a pre-plasty. Then we would deploy a stent right away. The stent is, like I said, a wall stent. It is a nitinol stent. If required, we do a post-dilatation. And almost always, as soon as we do the angioplasty, there is a transient bradycardia and hypotension. So we tell the anesthetist to observe very carefully because sometimes, rarely, the patient may go into asystole. So these are the steps. This is the DSA. We cross with a wire. We deploy the filter. We bring a balloon, do the angioplasty. You can see the way the balloon opens at the site of the stenosis. Then we deploy the stent. If required, we dilate the stent if the stent does not open. So if the plaque is calcified or if the plaque is hard, woody, then it does not open. The stent does not open. Then we do a post-plastic. And we always look at the carotid circulation. So this is an example. Patient who seemed to have a minor stroke actually had a big stroke. Over the next 2 days, it evolved, became a big stroke. So we waited. This is his MRA, shows an extremely tight stenosis. And this is the DSA. You can see how tight this stenosis is. And there's another one in the common carotid. So it's a very complex plaque in the anterocerebral artery is not filling, the intracranial circulation is very slow. We always look at that. We look at the cross flow from the other side, very good cross flow from the other side, no stenosis on the other side. But from the vertebral, you can see that the external carotid is filling very well. So we always look at all the collaterals. Then we cross with a wire and we deploy the steps, take the steps as I said earlier. So in this case, we have used a Protege balloon, the Protege stent, and this also has a very good radial force. So not always do we do a post dilatation. And this is the final post. It will open further. Sometimes the plaque may shift and cause occlusion of the external carotid. This does not worry us too much because the external carotid always has very good collateral with the other side. So this is what the stent looks like. And very often we see that the anterocerebral artery, which was not filling earlier, starts filling very well later. So this is a gentleman who had pre-operative stenting, and you can see how bad this carotid is. So such a patient, if he were to undergo bypass, the chance of his getting a stroke is high. We had one recently where the patient got a stroke. It was not realized that the patient has a stenosis. So some cardiac surgeons insist on imaging of the carotid in the neck, because when they turn the heart over for the posterior artery anastomosis, there is a drop in blood pressure, and that is enough to cause a stroke in these patients. So in this patient, you can see here the anterocerebral artery is not filling before we had done the stenting, and post stenting it is filling so well. This is not uncommon. In fact, we see this very often. The anterocerebral artery filling very well. This patient had a contralateral occlusion. Dr. Ambekar made a point that if there is bilateral stenosis or contralateral occlusion, it doesn't like to do an operation. And that is because if it is totally dependent on one side and you occlude the artery for 20 minutes, unless you use a shunt, which even with a shunt, to get the shunt into position, it takes 2 to 3 minutes, during which there is complete circulatory arrest. So when we do this angioplasty of patient like this, we are very careful to occlude the artery for just 5 or 10 seconds, not more. We do the angioplasty fast, in and out very fast. Bilateral carotid stenting in the same sitting, never for us. I don't like to do it because we don't know what will happen to the cerebral circulation and the cerebrovascular reserve. But we have done carotid and vertebral or carotid and subclavian in the same sitting. Like in this patient, we have done the carotid and the subclavian in the same sitting. And this patient had bilateral carotid severe stenosis, as you can see. We have done at an interval of 4 days. Both sides were symptomatic in this patient. Complications, bradycardia, hypotension is almost always there. Rarely do we need to give noradrenaline to support the blood pressure. If there is contralateral occlusion and you're not prepared, the patient may get a convulsion. So, in fact, when the first time we got it, we were wondering what the hell happened. And then we realized that you have to be very fast with inflation and deflation. Filters, if the artery cervical ICA is very tortuous, it may be difficult to retrieve the filter. So you may have to do various maneuvers to retrieve the filter. Deploying is comparatively easy. Retrieval becomes a difficult problem. Embolism almost always occurs, but these are usually very small particles which have crossed through the filter, and usually these are asymptomatic. Reperfusion, the brain is relatively oligemic for months or years. We restore blood flow. There is always a certain amount of reperfusion. So some patients get headache, some patients become restless, some get convulsions. And sometimes, of course, the most dangerous one is hemorrhage. And we've lost one patient because of severe intracranial hemorrhage following the stenting. And this is usually because of poor reserve, and this is more common in octogenarians and patients over the age of 70. In follow-up, all our patients receive aspirin and clopidogrel, and we continue both for at least 1 year. We do a color Doppler at 3 months, 6 months, 1 year, and then one annually. And many of my patients come and see me even 20 years later. So in emergency, we try and use either a closed cell design or a double layered stent like the C-guard or the Caspar. Caspar we do not have available to us, but we do have the C-guard available to us, which we use if required. So this was a lady who was getting multiple TIs despite double antiplatelet, low molecular weight heparin, full dose, she was still getting TIs. So here we have done the stenting using a C-guard stent. So we would use a C-guard stent. On follow-up, sometimes there can be an occlusion. So this is a patient 1 week later. He came with a carotid occlusion. So we found that there was very good cross flow. So we didn't do anything. We just raised his blood pressure, gave him a double dose of antiplatelet, and he recovered. This was a patient in whom, again, a week later, he came back with TIAs and some weakness on the left side. This was right-sided stenting. And we found that he had so when we did his imaging, we found he had fresh infarcts on the right side. And we found that there was a thrombus inside the stent. The stent was completely occluded. And this was immediately post-procedure. This was when he came for follow-up. There is no flow into the internal carotid. The stent is totally occluded. And here we have to aspirate. And when we aspirate it, you can see the way that so here we are aspirating and we suck this clot out. So this is the clot. We got huge clots out. And the artery was completely normal afterwards. So this patient subsequently did okay. So this is his cerebral circulation later. He's doing very well. He's been on follow-up now for a long time. So stent thrombosis and stent occlusion is rare, but it can happen and we have to be prepared for it. And usually it occurs several weeks later. So in conclusion, carotid angioplasty and stenting is safe if done carefully in selected patients, always under road mapping and always using protection device. Thank you for your attention.
Thank you, sir. We will have all the questions at the end together. I request Dr. Shiv Shankar to come ahead and make his presentation on ST-MCA bypass.
Yeah. Good evening. My screen is seen, right?
Yes, yes, yes.
Good evening, respected neurosurgeons, and thank you very much, MCNS webinar committee for giving me this opportunity to share my views about how I do ST-MC bypass. It is just 3 weeks before the conference and the microvascular osmosis that we'll be having in one of our MCNS. So as we all know that in terms of energy metabolism, the brain represents 2% of the total body weight, but is responsible for the 20% of oxygen consumption, 25% of glucose consumption, and it receives around 15 to 20% of total cardiac output. So we are very much in that way. The brain is very important, and we need to know the importance of microvascular anastomosis, in particular these diseases. The diseases which affect the vessels of the brain and spine, they carry high mortality and morbidity if not treated well, and it needs rigorous training for neurosurgeons when we get trained during our MCH or DNB trainings. So with the advent of endovascular treatment, there is a significant decrease in the number of the way aneurysms and the AVMs are being treated. And even with the advent of flow diverters, the high flow bypasses that they were required for mainly the large aneurysms has significantly decreased. So to stay distinct and skilled in our field, and we need to acquire new skills, including anastomosis. So usually we do this ST-MC bypass. Coming to only this ST-MC bypass, we use this technique for Moemer disease, where we do a combined procedure, where direct and indirect is combined together. And in case of chronic occlusive vascular diseases, and also in few cases of untreated aneurysms, mainly the MC aneurysms, which are fusiform or mycotic aneurysms, where we need to take out the vessel segment. In those cases, or in some cases where the vessels are encased with the tumor completely, and we need to take out them. So by mastering microvascular anastomosis, we can expand our treatment options and improve patient outcomes. So anastomosis is a routine procedure as a general surgeon we used to do for these intestines, and it is routinely being done by our cardiac surgeons for coronaries, and our plastic surgeons do it in most of the trauma cases. So here in this 15 minutes, what I will discuss is how I do this anastomosis in case of STMCA, and the lessons what I learned from my 50 plus cerebral bypasses that we did in the last 6 to 7 years. So the difference between what we do here in the coronaries and what we do here for the anastomosis for the intestine, the difference here is that we are dealing with the brain, and the vessels are quite small here, and they are eloquent, and we have to finish off the anastomosis in a stipulated time. We cannot pull on for a long time, otherwise the ischemia will set in. So as we know, that time is brain. So these vessels are quite deep and they're small, and they're surrounded by the eloquent brain tissue, which we can't afford to damage, and even the veins around. So that's how this is different. And the other difference is that the instruments what we use here are quite small, because the suture materials what we use here are very small, like 80, 90, and 10 suture materials that we use for anastomosis. So hence this procedure becomes difficult. And we need to retrain ourselves on multiple occasions by attending workshops and watching the masters doing the same procedures. So I would like to discuss this under the following headings, mainly patient selection, which is quite extensive, and I will not be able to cover the whole topic of the patient selection here. And I believe that studying the images is very important, because we need to see that which are the areas where the deficiency of blood flow, where how are the collaterals, and how are the vessels which are going to donor vessels, like mainly STAs, how they are, and how is the recipient vessel where we are going to anastomose this thing. So we need to study these images carefully before we start our procedure. So, so these are the vessels that we study on CT angio or on DSA, and we should know the normal anatomy of the STA in cadavers also. So coming to, we start with the anesthesia. Anesthesia, mainly two things to be avoided. One is hypotension and even hypovolemia, mainly for myomyosis diseases. And we use heparin, we load. We continue with the echosporin 75, which is usually routinely continued for all those patients. We continue with minimum dose of 75 mg echosporin the pre-operative and even the post-op also. And intraoperatively, we load with around 75 to 100 units per kg of heparin just before we clamp the recipient vessel. So once we prefer to keep the patient flat, so that we expose the complete STS trunk, even the frontal and temporal arteries, and then we gradually open the incision to harvest these vessels. So once the vessel is harvested, it is quite important that how we take the vessel in without damaging the middle meningeal artery, which is quite important, because even it contributes for the collaterals which supplies the myoma vessels. So then we should know that which territory is deficient, mainly by studying the perfusion images, that which part of the brain which is having a deficient blood supply, so that we can select those vessels as a recipient and we can do bypass. So once that is done, we put these clips and then go into the arteriotomy, and then then we prepare the donor vessel, the mainly STA. We have to take out all the connective tissue and even adventitia, and then we do something called as rather than this thing transverse arteriotomy, that gives us heel and knee, and then we do a fish mouthing, and we preload with the heel and nose, knee sutures, and then we can do the completion of the anastomosis. So it is very important about even knowing of the closure, because when we exit, these vessels are quite small. So we should not inadvertently handle the tissues, so that the anastomosis breaks open or the vessels get kinked, or while suturing also they get suturing or keeping the bone flap, they should not get compressed by the tissues or even the bone. So post-op image studying is quite important. We routinely do CT angio in the immediate next day, and in follow-up we do DSA. And we can see here that under the kinetomy there is a defect to which the ST has gone inside. And so this is a beautiful image from Sri Chitra that I see, that you can see the both the STAs are anastomosed here in this particular disease case. So I would like to show this video here. So I feel
Surgical video demonstrating double barrel
Is it audible?
STMCA bypass done for myoma disease.
Yes.
She is a young nurse who presented with
is volume
recurrent
okay?
episodes of bilateral stroke in the span of 15
Yes,
days.
yes.
And
So
this is
this
a
was a
DSA which
female, you
shows
can see
complete
here.
occlusion of left side
Play
ICA and
from here.
90% occlusion.
So this particular case, that principal patient, that she was 37-year-old female who presented with these acute bilateral infarcts here. So these are bilateral infarcts. He initially presented to the right side, then to the left side. When he came to us, he had hemiparesis, and she was aphasic, a staff nurse, 37-year-old. And this is what we can see in DSA. The ICA is completely occluded. We are not able to see any proper form vessels here. And we can see the tortuous STA there with the frontal and parietal branches. So this is the myoma vessels that we formed, and this is how the posterior circulation is supplying the much of the anticirculation. And because it was insufficient and the patient was having recurrent infarcts. So there are no correlators, and this is what is notable here. As I told, we need to study these supratemporal artery properly because we need to harvest them, preserve them, and we need to prepare them for anastomosis. And if you lose the vessel, then the whole procedure becomes completely waste. So we use general anesthesia. We clamp the patient to the Mayfield head clamp, and then we mark the STA using the Doppler. So handheld Doppler, we mark the STA. You can palpate the vessel very well, and you can mark it. And once you mark with the permanent marker, after incision, sometimes it goes. So we do a faint needle marking over this vessel so that we don't lose them even after draping also. So I usually prefer to use a curvilinear skin incision rather than a question mark, because these supratemporal artery are meant to supply the skin area. And in some cases where you need both the double barrel bypass of the frontal and parietal branches, these patients end up having vascular necrosis of the skin because they are meant to supply the skin, and we are stealing that blood to supply the brain inside. So for that reason, we prefer to use the curvular incision rather than a question mark incision. Then after that, we raise the temporalis muscle and pass the STA branches so that the muscle is not compressing them. So then we do go ahead with the peritoneal craniotomy and expose the dura or the MCF base. And then we choose the recipient vessels, mainly M4. And after that, we have to prepare the recipient vessel, donor vessel. And this is how we proceed. And this is how the patient is positioned here on the Mayfield head clamp. The patient is flat. And this is how we have marked the STA using a Doppler and using curvular incision. We went ahead with the opening of the wound. So once the incision marked, this is how we open. We all know that the skin has 5 layers of the scalp, and the STAs are housed in the loose tissue.
Are you showing the videos? We are not seeing the video. If you're showing the video,
yes, it is a video I'm showing.
Yeah, no, it's not being shown on the screen.
I'm seeing the.
We are seeing you. We are not seeing the video.
No, we are seeing the video.
No, sir, we are seeing the video. You
We are
need to
seeing the video.
double click on the small video icon.
Oh, okay.
We are seeing the video.
Okay.
Sorry, my fault here.
Yes, sir. So once we mark the skin incision and we go into the loose tissue, there are different ways of harvesting this vessel. I use a sharp knife to cut this, and there are many other people who use a sharp bipolar for dissection, even if you use a pointed monopolar. So I'm comfortable with using this 50 number blade. And we all know that as we saw in the DSA also, and normalotomy, that STA has doesn't have a straight course. It has twists and turns. And mainly on the outer borders, this is where the branches arise. And we need to clip them or coagulate them quite away from the main harvesting vessel so that we do not damage the adventitious of the vessel. So usually we harvest about a length of around 8 centimeters of STA. Mainly from the zygomatic arch to the supratemporal line, that is what, around 8 centimeters, or you can measure during surgery also. And once this tissue is raised, and the final, you can see that there are few clips we have put. There was a branch, and this is the final clip because the length is adequate. So I'm harvesting the STA completely using this clip there, micro clip. And after that, we have raised this STA with the connective tissue cuff around. So this is the STA, and in case if you need, you can harvest even the both the branches, that's the frontal and parietal branches. So once that is done, in this particular case, because I was unable to pass and I thought the vessels will king, so I had to split the temporalis muscle, which is usually not advisable for the myoma cases because the temporalis muscle has a robust blood supply to the brain. So once that is done, we take these vessels, both the vessels inside the craniotomy area. We have already done a pterional craniotomy. And these are the vessels which are lying in the craniotomy field. So there are two ways, two main purposes of taking them here. One, to check the length of the vessel over the frontal and the temporal area. And other is we have to see that the vessels are not kinking. Once we anastomose, if the vessels are kinked, the anastomosis will not work. So once they are brought into the field, the dura is opened. While opening the dura, you should be very much careful that you should not damage the middle meningeal artery, and that we have to preserve here. So you can see that I have kept a suction catheter underneath. That is the routine practice that what I do. So once the vessels are brought into the field, so you know that we have harvested with the connective tissue cuff around. So at least for a centimeter or 1.5 centimeter, the connective tissue has to be completely taken out, including adventitia, because they come in the suture, while we are suturing the lumen. And sometimes we not suture the whole wall, and we might suture the connective tissue. And the adventitia turns inside, and it's quite thrombogenic, and our anastomosis fails. So it's very important to prepare this donor vessel so that it has to be completely denuded from the connective tissue, including adventitia. So that is what I'm doing here under the highest zoom of microscope. So once that is done, we choose a vessel from which the at the part of arteriotomy, there should not be a branch arising. So then we do something called as a transverse arteriotomy rather than a perpendicular vertical arteriotomy, because this gives us a heel and toe appearance. And once that is done, this is the vessel which is completely ready, completely denuded. And once this is done, I release the temporary clip again so that I can check that the whole vessel is still patent and it is there is no thrombosis inside. So mainly when we harvest the radial artery for high flow bypass, we pre-fill with the heparin loaded saline. But since this is a live artery, which has only one end is open, the other end is connected to circulation. So we do not use heparin in this case, because you can see that it is very well flowing. There is no clots inside. So once that is done, we have to mark this vessel for the dorsal and ventral side to avoid the kinking of the donor vessel. So once that is done, you can see here that I'm marking with the marker here. We do fish mouthing. Fish mouthing is very important. It increases the diameter of the anastomotic zone. So this is what you can see in the picture. So it becomes a quadrilateral surface area, and it almost quadruples the area for the anastomosis from the donor vessel. So once that is done, this is the recipient vessel. This has to be chosen wisely depending on the perfusion study what we do and the DSA what you have studied. And intraoperatively, the vessels what you see that it is not. Sometimes what happens is they're quite closely adherent to the main vein draining, and we can't afford to damage that vein. And sometimes there are vessels arising from this recipient vessel, branches arising. So we have to avoid those areas. So once the vessel is selected, we have to free it from the surrounding tissue. And once that the surrounding tissues that are freed and small branches, we can coagulate in these cases. So I pass this rubber dam underneath. So it helps me to protect the underlying tissue. And I keep a suction under because I use quite copious irrigation during my procedure. And this is what I do, that the suction is continuously there. We can irrigate and the suction is suctioning and there's no blood there. So once that is done, we bring this. You can see that this is a hood of a snake, like something like that. And then we mark the surface area, the surface of the dorsal surface of the donor vessel, so that we have two surfaces. One is the ventral surface, the dorsal surface. The dorsal face we are going to cut and do it in arteriotomy. So we need to see the walls, the cut walls, which are bluishly colored. You can see here during the procedure. So once that is done, we prepare ulcer. So I use these two gel foams. So I use two suture materials, 90, two cut ends, and keep on that side and keep on this side. The main issue with these anastomosis of STMCA is the vessels are very small, and the instruments and the suture materials what we're going to use will be very small. We cannot see them with the naked eyes. So we have to work under high zoom magnification. So when you're working with both the hands in such a high zoom magnification, either he has to use a mouse switch or a foot control to do a zoom in, zoom out, because while doing a suture, I will show you here. So this is what I do, that we preload it, because every suture we take here matters, it consumes the time. So by preloading this vessel at the heel and knee, the donor vessel, so we preserve some time, we save some time. So then we preload this what I advise the younger colleagues is that handling these instruments and the suture material is everything, because we all know that putting suture is simple for every cases that we do, and the same sutures we'll be putting here. But only thing is the depth at what we're working, the instruments what we're using, and the suture material is what we're using is makes a difference. So once we practice and practice and practice these things, mainly what I learned was in most of the current incisions which we open at the question mark, we tend to cut one of the STA branches, and I used to anastomose at the end of the procedure. So once the whole procedure has a seam closure, I learned anastomosis doing this, and I can see the live perfusion also. So this is what I'm doing, outside to inside and inside to outside. This is how we take the sutures. And once that is done, I put the distal clipper, then the proximal, and then using this insulin needle, we do a arteriotomy. I don't have a luxury of having a diamond knife, which costs around 8 to 10 lakh rupees. We use this thing, and this is how we cut the. We do an arteriotomy. So this is not a good case of doing arteriotomy, because you can see the ragged edges there. That should not happen. So once we enter without leaving the lower edge of the scissors, we should go on cutting. So it gives us a smooth edge, and that will be good for a vessel to get anastomosed. So once that is done, first I put this heel end there, and then toe end. Then we put sutures. I use around 4 to 5 knots here every time we use. And these are the heel and toe end put. And after that, what I do is I put 2 sutures just beside the heel and toe end, total 4 sutures. And then we continue with the sutures interbetween. And a main issue here is sometimes what can happen here is, you can see here, the vessel wall from the opposite side come in, and you can suture, you can include that part. So then that has to be avoided. And once that is done, we use around total around 8 sutures on that side, 8 sutures on that side, heel and toe. So these are the sutures that we use. And once that is done, this is the last suture I'm taking. There was some remnant. We have to be very much careful. The arteriotomy that we have done on the donor vessel, and the fish mounting that we have done on the recipient vessel arteriotomy and the donor vessel fish mounting, the diameter has to match. If there's a mismatch, we might damage the anastomosis, and the suture might cut open. That has happened with me. That has to be very much precise and perfect. So once that is done, this is the last suture we are taking. So with that, this anastomosis is completely over. So you can see here that the complete anastomosis is over. The vessel is lying very well on that. And these are the sutures. These are the temporary clips that are put on both the sides. This particular case took around 20 minutes for me. And you can see that absolutely there was no clogging of the blood or the even the saline, because it was being suctioned by a suction underneath the rubber ram. So that continuously sucks this blood and keeps the field very much clean. So once that is done, we release the distal clip first, because most of the time it leaks. You can see here in between the suture materials, sutures, the blood leaks. And then once that is set, then we release the proximal clip that supplies the blood. And then after that, at the end, we release the clip over the superior temporal artery. So once that is done, we confirm the anastomosis. We had a demo piece. We don't have a microscope that has an ICG. So there was a demo of kinemo that we had to actually. So I had that luxury of having this ICG. And now today we have brought on Pentero. And usually I use a Doppler to study the patency of my vessels, the donor and recipient's vessels. So this is a satisfactory thing that we can see at the end of the procedure. We anastomosed 2 vessels here, or the frontal region and the temporal region, and both are beautifully there. They're lying down. There's no kinking. There's no pulling. The length is not short, and they're freely lying there. And this is what we saw even in the ICG. And this is quite important to know here that once it is done, the closure is also quite important. So the closure proceeds like this. Once these vessels are anastomosed here, the dura has to be closed. So while closing the dura also, you should not disturb these vessels, or should not include or should not constrict the dural closure, so the vessels get constricted. And once you keep back the bone flap back, the bone flap should not press over the arteries and should not occlude the flow. So we need to make a window over there so that the vessels pass. And same with the closure of the temporalis muscle also. And it's very important to put the last stitch near the STA trunk. So if you go deep, mainly the subacute Gallial sutures, what we take. So if you go deep, you might damage the trunk of the STA and whole STA anastomosis goes vein. So this is what we see here. So this is a beautiful post-op bypass. DSA, you can see this is the pre-op one. The IC is completely occluded. What you can see is just an STA lying over there. Once we anastomose both these superior temporal arteries, the frontal and parietal branches, beautifully the brain is being perfused here. So you can see the whole MCA, even the ACA territory down to the callosal area is being perfused, and this was a successful anastomosis. So this patient did well, and this is the DSA you can see here. So we need to know about the complications also here, because the complications start from the skin incision itself. So when you're harvesting, you might directly damage the main vessel. That should be completely avoided, because that is the only vessel that is there to perfuse the brain of this patient, and that has to be handled very much carefully. And even while you are preparing the graft, harvesting the graft, you should not damage in between, because proper length is required. And once you take inside, you take around at least 1 centimeter, 2 centimeter more than the location where your recipient artery is there. So that there should not be a pull over the vessel. Or when you are preparing, when you are completely denuding the distal end for this thing, fish mouthing, you might sometimes tend to damage the vessel, and you should keep an adequate length while preparing that. And the same thing while anastomosing, you should not run over time and give an infarct to the patient. At the same time, we use heparin that I told that we load around 70 to 100 units per kg of heparin after putting the temporary cap over the recipient artery. So even closure is important. So every step here is quite important, and only difference here, what I tell is that is the instruments what we use, the vessels, they are quite small. So this is how we have to get trained ourselves. We can do it very well on any cases where you inadvertently cut the STA, and you can anastomose at the end of the procedure. So thank you very much. I think I have completed everything that I was supposed to tell. And it is quite a good opportunity for all my younger colleagues and even neurosurgeons that coming February 14th to 16th, we have a Midwest chapter of neurosurgery conference. It is being attended by around 300 plus neurosurgeons across Karnataka, Goa, and even India, and few from across the world also. And we have beautiful workshops, and one among that is the microvascular anastomosis workshop, wherein we have 13 table-mounted microscopes, goat arteries, chicken arteries. We are going to do a dry anastomosis workshop and a wet, wherein we can use these vessels. And it will be directed by none other than Professor B.K. Mishra, sir, who started, probably the first person who started the workshops in India, and who has a big name in vascular neurosurgery and anastomosis, and Dr. Janan Sudhir from Sri Chitra, who has done around 200 plus anastomosis in his career, and I'm the third faculty here. And we also have endovascular hands-on workshop here. We'll be having around 4 to 5 models wherein the delegates can have the hands-on experience of doing DSA, coiling the aneurysms, and even doing putting a flow diverter and stents also. And you can learn from none other than the masters of endovascular treatment, and the pioneer, Dr. Anil Karapurkar sir, Dr. Batuk Diora, and Dr. Nitin Dange and Chaitanya Godbole. So I welcome you all, and I end with this note. Please do register for the conference. There are almost around 160 registrations so far, and around 60 registration for the workshop also. So it is from 14th to 16th, and 14th is a workshop. And 14th evening, we have 7 to 9 p.m. Dine with Wine session, where we have around 8 talks, followed by 15th, we have inaugurations, plenary session, many talks, and till it goes up to the Sunday afternoon. So welcome you all to MCNS. Thank you very much.
Thank you, Dr. Shivshankar. As I always said, cadaver workshops are the best way to celebrate a Valentine's Day, 14th February in MCNS Kolhapur.
Yes.
So, I would now open the house for discussion with our panelists. I would request, B.K. Mishra sir to say if he had any particular comments about the carotid end arterectomy and the STMCA bypass, the surgical techniques, if he had any particular way he does it differently from what was presented?
So both the presentation, the surgical presentations are beautifully done. I'll just first comment about Sudhir's presentation. Very, very nicely, he had outlined what are the precautions one need to take. There's some few things which I do differently. Number one, we always, and I think he emphasized that also bringing the blood pressure up and giving the heparin before clamping. We usually give the heparin and we clamp after 3 minutes, and we bring up the BP about 20% up than the basal BP before clamping, and we bring down the BP before opening up the carotid artery to the normal tension. And that's what I think is very, very important. The one thing which I do differently, number one, is we hardly do any DSA today for the carotid study. We always have a CT angio, which Dr. Karapurkar mentioned that they don't do CTs. We do CT always because number one, it helps us to get the skeletal, the high, how high the bifurcation is, how high up the you need to go beyond the occlusion. So you need to have, and today we don't, I mean, the mandibular thing is actually history, because we really, there's very little difference between endarterectomy and stenting today, the data suggests. So if you have a very high bifurcation or the occlusion is going high up to above C2, we don't advise endarterectomy today. Our indications for stenting are limited. Number one, if the patient has a cardiac disease which is unstable or a significant cardiac instability, because we do cases under general anesthesia, somebody who is not fit would go for stenting today. A high bifurcation or a very high above C2 going occlusion goes for bypass, goes for stenting. A patient who has had radiation goes for stenting. A patient is a redo more often goes for stenting, though we have done few cases of redo. Bilateral occlusion, bilateral carotid, we do it. But if the one unilateral has any compromise of the cranial nerves, then he can say second side is a contraindication. But we have done a few cases of bilateral carotid endarterectomy. One thing which I do significantly differently, we don't do any patient with the graft. It's a primary closure most of the time. We have in 100 consecutive cases, we had only used twice graft. One was a redo, and the other was a very, very thin artery, so that we had to use it. Once we had used the vein, and once we had put the graft, the artificial graft. The shunt in 100 consecutive cases, we had used only 3 patients. We needed shunt. We use monitoring of EEG, continuously EEG monitoring. And so that's our monitoring, mostly our monitoring. The closer and the opening, the closer is slightly different than what Sudhir said. Not very different, but important to occlude the internal carotid, like he said. And that's very, very critical that you occlude the internal carotid so that you do not have the emboli going up when you're handling it. So that's critical. Beyond that, after internal carotid, I occlude the common carotid and then the external carotid. The logic behind that, if you occlude both internal carotid and external carotid first, and then occlude the common carotid, there is some risk. You are putting too much of pressure on the artery. So my closure would be internal carotid, common carotid, and external carotid, and in between, the superior thyroid is occluded much earlier than that to save time. And opening, like what he said, is appropriate. You open the external carotid first and then open the common carotid next. And then we usually wait for about 10 seconds for the debris to go into the external carotid circulation. Then we open up the internal carotid. Other than that, this is very, very similar to what Sudhir said, except the fact that we don't do DSA anymore. We always have 2 studies. And we usually, if the patient has a study much before then he came to us, we usually have a Doppler before the day of surgery, because sometimes the things change. Sometimes the artery might have occluded in the meantime. So one has to be very, very careful about it. We had a couple of patients where the carotid had occluded by the time he had come to us, but though he was patent. the one case which showed very, very important finding that MR shows that it was occluded, where the CT angio did show that, and MRI always overrates it, so that one has to be aware of that. So the CT angio is more accurate, and it gives you the little more, if you combine CT with Doppler, that's almost always gives you all the information you need for a carotid endarterectomy. Most of the patients have already come with MR to us because the first investigation they have the MR, and it's important to have both the MRI of the brain and the neck vessels. So when we do the CT angio, we only do the CT angio of the neck. Otherwise, it's a beautiful demonstration of what he said and what precautions, and I think that was all very well done. Sip Sankar, very nice demonstration, and he is been putting off videos which are very high quality videos. So very good. I think we very similar. The only other thing which I think I don't know whether Sudhir emphasized. I do the carotid endarterectomy skin incision under the microscope. The incision starts under the micro. Everything right from top beginning to the end is under the microscope. Similarly, on the STMC, my incision starts with the microscope, and I do single vessel, not double barrel. Mostly my cases have been single vessel disease, single vessel anastomosis. A few cases we have done double barrel, but mostly single vessel. And I think Siv Shankar emphasized everything. The only thing is I like to emphasize you start the skin incision under the microscope, and the donor vessel, I take it distal to proximal. Some people like Paritos, I think, does proximal to distal, but I find it easier to from distal to proximal. Other than that, I think Sip Shankar has emphasized all the points. I don't think I do anything differently than what he said, except the fact that I think he does more double barrel. I don't do. I do mostly a single vessel. And most of my patients have the STMC direct is always combined with an indirect. I don't understand why he said you don't split I actually always split the muscle, temporalis muscle. That's the only thing I do differently. I always split the temporalis muscle, and the muscle always goes the dura is infolded, and that's a extra addition to the STMC. The muscle goes on the brain, so it is actually muscle split, and the arteries goes between the split muscles. And it's very critical, which is emphasized the fish mouthing, the distal clips first, and be very careful when you're closing so that you do not occlude the recipient vessel. But very well done. I think these are my comments.
Thank you, sir. So, may I ask one question to Batuk sir? Batuk sir, what are your indications for stenting versus endarterectomy? Is there particular situation you would do only stenting, or in the particular situation you will do only endarterectomy? I think
Chandan,
sir, yes, sir.
Chandan,
You also showed the slides.
No, can I say something before
Yes, sure, sir.
before
Yeah, sure,
you
sir.
go on
Sure.
to Bhatt? Yeah.
Yes, sir. Yes, sir.
So, Dr. Mishra
Misra.
just now, yeah,
Misra.
just now mentioned MRA. Now, why we like MRA is, of course, you cannot see with the bony landmarks, so you don't know how high or low it is, but you can see the intraluminal thrombus on a DSA. Intraluminal thrombus is one thing that you may not see on a CT angio, on a Doppler. You may see it on a Doppler, but usually it is not seen on a CT angio. It is not seen on an MRA also. It is seen only on a DSA. An intraluminal thrombus. So that is one thing. Second thing, why I like, again, I said, apart from the calcification, is that MRA, we always do with contrast. If you look at the TOF, the time of flight MRA, then an artery we have many such, where the artery appears occluded on the TOF. But if you do a contrast MRA, even a very tight stenosis, like the one which Sudhir showed, can be picked up on a contrast MRA. So, at least at Bridge Candy, we always do a contrast MRA in all our patients, especially for the neck. And one more thing about the surgical aspect, if we have an intraluminal thrombus, I said we have sent them for surgery. So I've operated on some of these. So when there is an intraluminal thrombus, Sudhir also mentioned you have to be more gentle with your dissection so that you don't dislodge. So if you know that there is an intraluminal thrombus, what we have done is we dissect above, we dissect below. We don't dissect at the level of the disease. So we dissect above level, then connect the two, and don't dab at the with the gauze or anything. So don't press. As far as possible, lift and dissect out so that you don't dislodge the thrombus within the lumen. Like I showed you on the angiogram, those intraluminal thrombus which can be dislodged. So that's all that I would have to say about the angioplasty stenting.
Just clarify. Most of our patients have already had MRI and MRA because they come from the neurologist who have been investigated. But every single patient of carotid, we have a CT angio. CT angio is a must for us
Okay.
because we don't do a DSA. I mean, unless the patient has already had a DSA, I don't do a DSA for anything. But everybody will have a CT angio and a Doppler. So these are the two things which picks up everything. And CT angio is necessary for the surgical part. For your endovascular, it's not necessary. Whether it's high, how high, low, doesn't matter. For us, it's a very critical thing to.
That I agree with
So
you.
that is why it is always, and I always, and Jagdish reports for us. He mentions where is the, where does it end, and usually you are on the side of, suppose he says C4, C3, I would say I have to be prepared to go to C2 because this is always a little higher than what you expect on the findings.
Yeah, I agree with you. So, intraluminal thrombus may be missed on everything. That is the thing.
Doppler would pick it up. For us, it's not a big
Sometimes
problem. You always, like Sudhir emphasized, the internal carotid is occluded first before we handle anything, before we open. So that takes care of your problem of endovascular because you are putting anything you put in there that can dislodge it. So we don't put anything inside. So that's why it doesn't
But it is
bother us very much.
better to know that it is there. If you know it is there, it is safer. Anyway, that is one aspect.
Yes, Chandan.
And about in 1 month, about Dr. Marjakke, most of the patients that we have done intracranial anastomosis, we have done a perfusion study to see whether there is in fact any area of hypoperfusion. And then we have done the anastomosis. In fact, Basant has been insisting on that earlier also, that we do perfusion studies before we undertake anastomosis between the EC and the IC.
I think that's very, very important point, Dr. Karapur. I don't actually do atherosclerosis disease for anastomosis. I think Sipsankar talked about it. We are very, very selective about it. And in fact, the neurologist has to push me to do for atherosclerosis. We have done a few cases where everything has failed, best medical management has failed, and there is an occlusion. Then only we go for carotid. But otherwise,
I myself sent you some.
So carotid occlusion, the data is so kind of confounding data, and evidence is so meager that you have to be very careful to advise STMC anastomosis unless until you have these perfusion studies with second line of hemodynamic compromise. Otherwise, the neurologist has to push me to do it. But I'm very, very, and I'm very, very happy to do it anytime.
Thank you, sir. Sir, Batuk sir,
yes, Chandan.
or your case selection.
Yeah, regarding the discussion about the CT angio, MR angio, and the digital subtraction angiography, as we are concerned about the presence of thrombus in a carotid at the level of carotid stenosis because it changed the indication, and that is the contraindication for a carotid stenting. That's the reason we are more concerned to know whether there is a thrombus or not. That is one thing. Second thing, as you mentioned about my indication for a surgery and the stenting. In my practice, we know about all the trials that is mentioned about the carotid endarterectomy and the carotid stenting, and still both are more or less comparable. And one of the trial has mentioned clearly those patients who are in a high risk for carotid surgery should be planned for a carotid stenting. So in my practice, I usually go for a carotid endarterectomy. The most of the patients Those patients who are a high risk for carotid surgery, I plan for a carotid stenting. Second thing, during the Karapurkar's presentation, I've seen he has mentioned about the youngest patient was 34 years and the oldest was 99. So many a times, like even though there is a standard indication for a carotid endarterectomy, that is a better option in a patient, but patient family demands, like they don't want to undergo carotid surgery, they want to undergo carotid stenting procedure. In those cases, I plan for a carotid stenting. Third thing, as Sudhir has shown in his case, somebody has tried. There was a critical stenosis. Somebody has tried to pass a wire, and it was not negotiable. Similar thing happens to me, like while doing a passing a wire and inflating the balloon. Unfortunately, because of the tight stenosis, balloon was not the vessel was not opening in spite of a multiple size balloon in the multiple attempts, and finally that patient ended with the carotid endarterectomy. So I have published a series of around 65 66 cases. I have almost 50% patient treated with the carotid artery stenting and half the patient with carotid endarterectomy. So in my series of these patients, I had a problem of two patients with the carotid stenting. One patient, as sir has mentioned about, one patient developed a hemorrhage immediately after opening the vessel, and we have lost that patient. And second patient has a major stroke. While in the CA group, hardly I had a one or two patient had some minor hematoma that doesn't require re-exploration. So these are my indications regarding the stenting and the surgery. Before we discuss about, I just want to mention about the Sudhir's presentation. Sudhir, you are nicely presented and shown the video of carotid endarterectomy. My concern about you have mentioned about after closing the carotid, you reverse the heparin. So I'm not sure, but in my practice, we usually do not reverse the heparin with the protamine. That is one thing. And second thing, I want to ask whether the use of patch, does the use of patch increase your overall clamping time? Because you have mentioned you are regularly using patch in your patients. And before I conclude, like I want to mention regarding the Shiv Shankar's presentation, very nice demonstration of STMC bypass, and you have shown a double barrel bypass. So are you doing a double barrel bypass in all the patients?
No, we don't do double barrel in all the cases. That particular patient who had an acute strokes, which were one after the other, that initially she had the right side, then followed by the left side, and she was a young adult. So I went ahead with this double barrel bypass. But otherwise, in Moya Moya, what we do is we take a single vessel and we combine with an indirect bypass.
So it was a Moya Moya disease or a syndrome, your patient?
No, that particular patient had a Moya Moya disease.
Okay, fine. Thank you.
Datta sir, Kishore sir, any questions to the panelists, speakers, any comments?
No, actually, very excellent presentation, very enlightening, beautiful demonstration, Shivashankar.
Hello,
And I think
hello,
Dr. Mishra has
hello,
covered everything. So,
hello. I just want to comment about the reversal. Kishore, just 1 second. If you just give me
sure,
1 second time, please.
yes,
We
sir.
also don't reverse the heparin unless until the using continues, significantly. We hardly ever reverse the heparin. That is something different, yes, which Batuk pointed out. Right, please, Kishore, go ahead.
Yeah, I was saying excellent presentation. Shivashankar, one question for you. Did I hear correctly that you said that you could do this in 20 minutes? And is that realistic, or 20 minutes is all it should take? Because we do take considerable longer time. I know time is not an issue, but just a bit of clarification on that. Otherwise, beautiful
Yeah,
demonstration. Very enjoyed
thank
it.
you. Yeah, she was an adult female, so the vessels were quite good, sir, with the donor and the recipient. So I could wind up early, but mainly in kids, it takes a little bit more. In wherein the thin, fragile vessels, I take more time. But in that particular case, since he was adult, the vessels you could have seen the video. Even the recipient vessel was quite good, and even the donor vessel, so, and they are perfectly matching. So I could finish off in 22 minutes.
So,
Very good.
Shivshankar, why are you worried about splitting the temporalis muscle? Did I hear correctly? What was the?
Yes, sir. So I believe that while cutting the deep temporal artery get cut, sir, and the supplying when it is supplying the flaps, the vascularity of the flap that we use for indirect placement over the brain. So the vascularity for that particular muscle flap get compromised.
No, but if you don't split, how do you get the vessel inside if you're putting the muscle?
From the other end of the temporalis muscle cut where our cut, sir, on the side.
And
Yeah.
one quick comment. Do you know something? For atherosclerotic disease, we are not allowed to do STMC bypass. Not only we don't do, we are not allowed to do them anywhere in the country.
Yes, sir.
So I think I can make the last comment maybe. So I think the presentations were quite good and it was a lot of learning for me as well. Only two questions. In my small practice, I have done a lot of indirect bypasses for Moya Moya. And to be very frank, on being on the other side, they have worked quite well over the past 20 years. So I may not have done as what Batuke started at KEM, but indirect bypasses has worked well. And as I'm always hear Professor Mishra saying that he does both. And in the initial years, if the direct doesn't work, then the indirect at least take cares of the vascular head in the long term. So that is one question. That is one comment. And second is about the cost. I think nobody has talked about the cost. So does cost influence carotid stenting versus endarterectomy? And the more flip side, where stenting has been easily advised and done nowadays because of many reasons, is CEA falling short of experience, or what will be the future? Because I don't see a lot of people doing CEA because of the stenting being taken over by this thing. So that is a concern for me as far as the teaching faculty is concerned. Any comments on that, sir? Dr.
Karakul, sir.
Dr. Mitra?
Sir.
Cost-wise, the material cost for a carotid stent comes to around, we don't reuse anything. Everything is fresh for every single patient. It's about 1.5 to 2 lakhs, the material cost. Hospital cost then depends on which hospital you do it at, and there are other things. As far as what was your other point?
The other point was the
teaching.
dwindling experience of CA.
The number of endarterectomies being done in India has always been abysmally low. Very low. Very few are doing endarterectomy. Even before all these years, all these decades, except for Basant, who has been doing regularly, and Keki Turel, who has been doing regularly, I think very few in the country have been doing endarterectomy. So even the very busy vascular surgeon has done not too many endarterectomy. Even Basant mentioned 100. Whereas if you talk about carotid stents, over the last, now we have been doing for almost 30 years, I've done almost 1,000 carotid stents. So the number is huge. And today, raising 1.5 lakhs, 2.5 lakhs, though it seems a big amount, I think from government support, they do come and get it done. But on the other hand, the skill should be preserved. There is no question.
That's one.
That has to be preserved. You have to make sure that people are trained to do
I've
it.
seen at KEM, Dr. Nadkarni was doing endarterectomies when we were in the early years of our. He has done a lot of endarterectomies. He has done maybe, I was there, about 35, 40 endarterectomies. But after that, the things have changed when different type of stents have come, the popularization of stent and patient preference. And the incidence of carotid endarterectomy at KEM had gone down considerably over last 10 years, 10 to 15 years. So that's the reason I was asking that whether patient preference comes into play, and the stents becoming relatively amenable to the patient.
It's very Majumdar. There's a couple of things. Number one, about your indirect and direct.
Yeah.
There is very little difference in the outcome in pediatric population.
Yes.
For indirect, in fact, is probably better because the complications are less, and there are studies which are, there are studies on either side, but very little difference between indirect and direct in pediatric. Probably it is better to do for young children. Indirect is probably better.
That's right.
As you rightly said, when you combine both, what happens is the immediate protection comes from the direct, But the long-term protection is, and there is just a very nice study from Chicago, where the long-term protection comes from indirect. So if you're doing indirect, it is better to combine with indirect. If you're not doing, I mean, pediatric adults, if you're adult moyama, the direct is always better than the indirect one. Now about the carotid, I have probably, I mean, I talked about 100 cases because we reported. We have now around 200 cases, but definitely less number than compared to stenting. It's critical for your neurology colleague to support. You can't do carotid endarterectomy and bypasses for strokes unless a neurologic colleague is, supporting you, because they are going to send you the patient, and your results have to match, because the complication, if you're not able to match the complications, then you will not get it. I mean, the colleagues will not send it to you. That as simple as that. So yes, numbers are going down, but as Sipsankar told, the bypass will still stay. The Maya, you have no choice. I mean, unfortunately for us, the endovascular still cannot take care of the Maya disease. So the skills will have to be developed with, the bypass skill has to be developed with Maya disease. And Kishore pointed out, there is a lot of auditing there. So UK is very controlled, so that is why they cannot do it. But US people do it still. People still do it, though. Numbers have gone down significantly before the NEJM kind of study came out about the ECIC bypass STMC for stroke. Now they have very limited indications for. There are but very very limited.
Yes. So pediatric population, there you are right.
Yeah.
Pediatric side, I get good results with indirect.
They work very well. There's no problem.
I think we are awaiting the CREST 2 trials as well. I think that will also help in clarifying certain things. Datta sir, would you like to conclude?
Yeah. So are we?
Yeah,
Yeah.
before we conclude, there are around 40 members here. I take this opportunity to invite you all for Kolhapur MCNS 2025. Let us start with the workshop on 14th. We have a wine and dine session also in the evening from 7 to 9, and Saturday, Sunday. So almost there are 160 plus registrations now, and around 40-50 registrations for the workshop also. So we are expecting big numbers. I request all the medical college teachers to encourage your residents to participate in workshops, and even there are some slots left open for posters also. Thank you. Thank you very much. Welcome to
Shivshankar, what I think is all those who are present for webinar, they must have already registered. It's actually those who are not here, we need to push them.
So the people who are there have to get more people. That's what it is. So I take this opportunity. I think it has been a wonderful webinar and a lot of learning for me in particular. And I thank the speakers, Dr. Sudhir Ambekar, Dr. Karapurkar, Dr. Shivshankar, and the panelists as well. Always great to hear Professor Mishra and Professor Karapurkar giving their thoughts, and Batuk Diora as well. This has been very informative. And the participants, my co-chairman, Dr. Kishore Chowdhury, and obviously Chandan, my co-moderator, and the participants. I thank you very much, and we have a wonderful meeting at MCNS in Kolhapur, and we await the results of MCNS EC elections, and I think for a new committee, and then take it forward with all your support. Thank you very much.
Thank you.
Thank you. Thank you.
Thank you. Thank you all.
Thank you, sir.
Bye-bye. See you in Kolhapur.
Yes,
Thank you.
Yes, sir.
See you all in Kolhapur.
Yes, sir.
Bye. Good night.
Thank you. Good night. Good night, everyone.